Actually, it's a great pleasure and always an honor to present in Cairo, in Masr. شكرا لكم. And thank you, Professor Hisham, for paving the road for me. They gave me 15 minutes and they gave you 20 minutes. I don't know why, but anyway, I'll try to overcome the 5 minutes, and we'll see. So I have no conflict of interest, and I will start. As you know, we all know it's the wrong name for the disease. Polycystic ovaries, this is not the disease. I'd rather call it the female metabolic syndrome. And hyperandrogenism, polycystic ovary, and polycystic ovarian morphology. I add to that insulin resistance, chronic inflammation, obesity. And I will be sharing with you solely my own data on these all topics. So as we all know and have seen, it's a hyperandrogenic status with insulin resistance creating proliferation in the endometrial environment, endocrine metabolic inflammatory condition, and of course the phenotypes according to the Rotterdam. What's happening? We don't have a high levels of estrogen. We have unopposed estrogen due to anovulation that is strong mitogenic signaling. And what's happening with the insulin resistance? That's the bypass of it. The insulin, like a growth factor 1, will enhance the sensitivity of the granulosa cell for FSH, more follicles, and the other one, more proliferation in the endometrium. Interleukin 6, increase the aromatase, and more estrogen. Progesterone, of course, it's absent on this drama. So when you look at the endometrial thickness in women with polycystic ovarian syndrome, which is very important because one of the comorbidities or outcomes of polycystic ovarian syndrome for a long time is endometrial hyperplasia. And the endometrial thickness is very important. We have looked in our study, and which was published, by the way, in the Scientific Reports Nature group, about phenotypes and insulin resistance in these women with different phenotypes. What we found among Jordanian women, we found that the classical all PCOS criteria, Rotterdam criteria, the most prevalent, while the others are less. And we found out that most of the parameters, as you see, fasting insulin, HOMA, insulin resistance, and all of these were different between the phenotypes when the classical one having the more disturbing dysfunctions in all these hormonal upsets. And as you see here, I do the HOMA insulin resistance for all my patients. And as you see, in obese women, more than 30, it's more relevant, which is very logical. And as you see here, the comparison of HOMA values between phenotype 1 had the most important among them. Adding to this dilemma is the presence of oligomenorrhea and or amenorrhea. And as you see here, the insulin resistance increased with this. And I've done the statistics in our patients, and we found that it's 19 times fold increase in the insulin resistance in women with oligomenorrhea. We also looked at the obesity, and we found, by the way, we found out that BMI is not the decisive factor. It is the waist circumference. And I do waist circumference in all my patients. And the norm standards for females with is above 80 to 84 centimeters. This is overweight. 84 to 88, this is obese, and above 88 centimeters, it is morbidly obese. We looked at the endometrial thickness in women with endometrial and as a predictor for endometrial hyperplasia. And what we found, although the study was very small, we found out that around 23% of our ladies, I was very surprised. This was double-blind study by 2 experts to look at endometrial hyperplasia in women with long-standing polycystic ovarian syndrome. 23% had endometrial hyperplasia. Thank God none of them had atypia, but they had already hyperplasia. And as you know, this will process with unopposed estrogen will continue for a long time. And we found that women having more than 9.5 millimeters with polycystic ovary syndrome have an increased risk of having endometrial hyperplasia. Each 1 millimeter increase 28% of having endometrial hyperplasia. And I call it the axis of evil. Infertility and PCOS, insulin resistance, oligoaminuria, this definitely will lead, not definitely, but will lead to endometrial hyperplasia, and we must be alert about this. Obesity and PCOS, long-term health effects, recent evidence and guidelines. PCOS is a chronic endocrine metabolic disorders. Obesity and central obesity is amplifying the insulin resistance, inflammation, and hyperandrogenism. And as you see here, we have it has been women with PCOS definitely are more obese in all the studies, and there is more than 100 studies showing this. And if you look at the mortality of women with various types of cancer according to BMI and the uterus, the one with the relative risk of death in obese women will be around odds ratio around 6.2. It means obesity is an evil. And that's why, because most of these women will have more of the estrogen coming from the subcutaneous tissue, which enhance, it's as in opposed estrogen and proliferation in the endometrium. Independent risk beyond BMI. PCOS itself is an independent cardiometabolic risk condition. Obesity markedly increases absolute risk, but does not fully explain it. The international evidence-based PCOS guidelines classify PCOS as a lifelong cardiometabolic risk status. And look at these, all studies, fourfold higher risk of type 2 diabetes. Obesity strength association, but risk remains in non-obese even PCOS, in the lean PCOS. And the cardiovascular adjustment to BMI attenuates, but does not remove the risk. The cardiovascular risk is there. And in my own clinic, I do all of these the last 2 years. I'm doing all these cardiovascular risk and indices, and I encourage you, dear colleagues, to do these. And it's a simple calculation of the atherogenic index of plasma, the Castello risk index 2, atherogenic coefficient, waist to height ratio, lipid accumulation product, visceral adipocity index, a body shape index. And we actually, you are the first to see this. We just finished a study on around 200 something, 190 something, 190 patients, and we have found that PCOS, all the indices were markedly and statistically significant, and started to have a dietitian with me and a family medicine, especially on those with long-standing PCOS, to counsel these ladies about the possibility of especially on those with oligoaminuria, obesity, and a family history of cardiovascular disease and long-standing PCOS. These are real headache for the future internal medicine specialist. Cardiovascular mechanism in obese women, it is the central obesity, low-grade inflammation, endothelial dysfunction, insulin resistance, dyslipidemia, androgen excess. Recent reviews have shown that PCOS as a cardiometabolic risk state. Cardiometabolic risk state. Gynecological cancer, of course, it's there in PCOS. Because of lack of time, I need to move. The last slides are the most important one. Obesity, central driver for endometrial cancer, we talked about that. And the fatty liver disease is an important issue you need to follow up in these. Prevalence around 40 to 50%. Can you imagine? 40 to 50% in obese women with PCOS cohort. This is amazing. You know, we don't follow up. I started to do this the last 2 years. Of course, adding to that, obstructive sleep apnea, high prevalence in PCOS with BMI match control, contributes to hypertension, cardiovascular disease, reduced, and sudden death even. Sudden death. pregnancy outcome, and long-term maternal risk, obesity, PCOS, higher risk of gestational diabetes, hypertensive disorders, preeclampsia, operative delivery, macrosomia. It's not just a cyst or a follicle within the ovary. It's a long, multi-system standing disease that needs our attention. And unfortunately, our Arabic women are endemic with polycystic ovary syndrome because of a lot of theories. I will not be talking about them now. Mental health. The recent guidelines saying all women with PCOS must go screening for anxiety and depression. It's a must in the guidelines. Because depression, anxiety, body images, distress, reduce health-related quality of life. The guidelines in 2023, routine mental health screening. And when you have a higher score or suspicious of anxiety or depression, she must be referred to the needed specialist. Okay, I will move this about this as a chronic low-grade inflammatory condition. Evidence and mechanism increasingly recognized not just as reproductive endocrine, but as multifactorial syndrome with systematic inflammation. And if you look at these meta-analyses, they have found all these key findings that implicated in PCOS pathophysiology. It's a chronic inflammatory disease such as endometriosis at the same. I want to talk about insulin resistance. I'm not sure why it's still not in the guidelines, the insulin resistance as in the definition of polycystic ovary syndrome, because it has been there all the time. We talked about the cancer risk evidence from insulin resistance in women with hyperplasia and oligoaminuria, and we've showed that it's around 6 times more in women with oligoaminuria. Lifestyle first, COCP, of course, I love to use the drospirenone-containing COCPs and metformin or whatever insulin if she's having insulin resistance. 6-hormone binding globulin in PCOS. 6-hormone binding globulin, I use it as a follow-up every 6 months because it has been shown the most prognostic factor for future cardiovascular disease. The most prognostic factor. And it has been shown in all studies that the 6-hormone binding globulin is low in women. Because it's low, the high androgen, the free testosterone, you will have the whole cascade coming on. The other one I encourage you to do, the DHEAS free androgen index ratio in PCOS. You will find it low in women with PCOS, and we have found it low because most of the DHEAS will be of adrenal origin. But the DHEA, the sulfate form, is adrenal exclusively. But the dehydroepiandrosterone without sulfate form, it is of ovarian origin. So in PCOS, most of the testosterone coming from it. And if you find this DHEAS high, you should suspect adrenal tumor or adrenal origin. We have just, it's under publications, the DHEAS-5 ratio was markedly lower in PCOS compared to controls. We are going to, it's just under publication in the coming few months. The key messages. PCOS is a lifelong and systematic disease. Proliferation is the central mechanism. Proliferation is the central mechanisms. And if you mind me, women in the old days used to have around 40 to 50 cycles. Now women are having around 450 to 500 cycles. In Jordan, for instance, the first baby now on average around 28 years. And you know, our ladies are from the age of 13 till the age of 28, they are menstruating for nothing. Continuous trigger of ovulation in the ovary and continuous trigger of proliferation unprotected in the endometrium. And you wonder where is all these comorbidities are coming from. With this, I conclude my talk. Thank you very much.